Thank you very much for the opportunity to present. Pushing the envelope will be the title of my presentation. This is about an 86-year-old gentleman who had progressive reworsening dyspnea and one heart failure hospitalization at the time of visit. He was in New York class 3. The other past medical history had atrial fibrillation, dyslipidemia, hypertension, previous pulmonary embolism, which was completely treated, and a remote history of C3 fracture from trauma. These were his medications for his comorbidities, including Lasix for his heart failure. ECG of note was a first-degree AV block. His echocardiography showed a preserved ejection fraction, 65 to 70%. There was a moderately dilated right ventricle with moderately reduced RV function, severe pulmonary hypertension. There was myxomatous mitral valve with severe MR, which was a result of prolapse of the posterior leaflet at the two scallops P2 and P3 due to a ruptured cord. The posterior leaflet length was long enough for an intervention, and the valve area was very big for TIA procedure, and the gradient were also generous. Cath showed only single RCA disease, which was to be managed medically. So these are the echo images. You can definitely appreciate the very frayed P2 segment on this view, which is shown with some myxomatous changes. The mitral regurgitation is definitely very severe. This is a 3D image which shows a very frayed P2 segment with a wide width of the prolapse. There's also a P3 segment which looks smaller compared to the P3, which looks smaller compared to the P2, with this mitral regurgitation, which kind of is eccentric, hugging the anterior part of the leaflet. So the complexity of the case included a wider flare width, which was about 17 millimeter. It's usually recommended that they are more amenable when it's less than 15. There was a bigger flare gap. The preferred one is also less than 10 millimeter. This was about 13. There were two segments which were flared, P2 and P3, and P3 being involved, there was definitely a commissural component of this, which makes the complex procedure. And a wider jet, as well as the myxomatous changes of the mitral valve leaflet. So that's why usually these type of cases, if they are surgical candidate, you prefer to send them to surgery. But given his age of 86, we thought that we should offer him TIA. So in this type of cases, we aim for a good transeptal puncture. Usually from this by cavo view, you aim a mid portion, and then this anterior posterior, you aim posterior. Here we correct to go more posterior, and we had an acceptable height of 4.4, and we crossed via that point. So given the two segment of prolapse, we aimed to tackle first the medial segment, as is the standard practice, to start from either medial or lateral and then go more central. So this was the positioning of our clip, and the 3D shows it here that we're in the medial segment of the valve. We deployed the valve. We thought there was a good tissue bridge. However, you could still appreciate a flared segment residual here, and there is a regurgitation, although it doesn't appear big enough to make us worried. However, whenever there's an anatomical defect, we always worry that if you leave it alone, the recurrence of mitral regurgitation may be high. That's why we thought that it would be best to make sure that we secure that flare segment, which was medial. Given the commissural position of this segment, it was not so easy to position our clip. We had to come out like 2 times to have a good, adequate position. Here we were able to position it adequately, and we definitely abolished the medial jet, and you can't appreciate any flare segment at that point. The gradient after the first clip, which was XTW, was 3 millimeter. After addressing the smaller flare segment, we had to tackle the P2, which was the biggest. We brought in another second XTW. Given that the valve area was big enough and the gradient after the first clip was a 3, we were happy to bring a bigger clip. So we positioned it at this P2 A2 segment. However, we knew that given the width of the flare segment, we may not be able to address the entire pathology. So we were happy with this result. However, there was still acceptable jet lateral to the clip. We were happy with our position. Said that despite this, we definitely have to put another clip. The gradient was 4. You worry that another clip will obviously cause a more higher gradient. However, as I said, the valve area to begin with was good enough, and this was a large flare segment. We thought that a smaller clip may not address the entire pathology. That's why we thought that the third clip should be another big one. So we brought the third one, which was successfully deployed. Can you appreciate nicely how the grippers are bouncing with the leaflet? We secured it nicely and secured the P2 flare. At this moment, there was only residual, at most mild to moderate regurgitation, and the gradient didn't go up from the second clip. It remained at 4, which we were happy with. His heart rate was 55 to 60 beats per minute. So in summary, this was a 86-year-old gentleman with a severe degenerative mitral regurgitation who had limiting symptoms, a New York class 3, who was not a surgical candidate given his advanced age. We offered him a mitral clip with 3 XTW clips. There was residual mild to moderate regurgitation. There was no extra room for more clips. The gradient was acceptable. We reduced the left atrial pressure significantly. And we saw him a few days ago in the clinic at 1 month. His symptoms had significantly improved, New York 1 to 2, and his MR was still at the same severity level with a stable gradient, and RVSP had improved from 85 to 59 millimeter of mercury. Thank you very much.
Okay, thank you. Any questions?
You said he had significant pulmonary hypertension and RV dysfunction, but he didn't mention the tricuspid valve.
Well, there was mild to moderate regurgitation.
Moderate tricuspid regurgitation.
We don't think it needed.
And do you know what's happened at a month?
It was still mild to moderate at 1 month post. Yeah.
Challenging case, good result. Would you have considered catching the flail first as the first clip and then going after the smaller flail portion like P3, the medial?
Definitely a good point. We usually want to address the medial part of the pathology because it's more challenging to address first, so that the second clip you will do it much more in a feasible way.
Because if you catch the medial, let's say your gradient is already 5 now, and now you're trying to catch the flail and your gradient go up to 10, then what do you do? So try to catch the flail part first and then see what gradient you get, and then you can go after the smaller flail.